So today we're looking at the COVID-19 pandemic through a completely different lens.
Right. Not the virus itself.
Exactly, not the virus, but the secondary toll, the collateral damage that kind of rippled outward when global healthcare systems were forced into survival mode.
And it is such a critical perspective to take.
It really is. Welcome to the deep dive. We have a custom-tailored exploration built just for you, the learner, to navigate these findings. We are digging into a newly published cohort study. This is from JAMA Oncology, released in February of 2026.
Just recently.
Yeah, and it meticulously measures how the disruption of routine medical care impacted short-term cancer survival in the U.S.
Because when a system as complex and, finely tuned as modern healthcare experiences a localized shock, we expect a localized response.
Right.
But when that shock is systemic, when it's sweeping across every hospital, clinic, and supply chain simultaneously, the fractures appear in places we might not immediately anticipate.
Yeah, and the goal today isn't to rehash the early days of the lockdowns, right? It's to understand the quantifiable data we finally have access to.
Okay, let's unpack this.
Yeah.
Because the researchers utilized the SEER21 database to anchor their findings. And the scope of that data is just immense.
It is. For anyone tracking epidemiological trends, SEER21 is the gold standard.
It covers what, about 40%?
About 41.9% of the entire U.S. population.
Wow.
And that percentage is vital because it's not just a pocket of data from, say, one affluent urban center.
Or just one rural network.
Exactly. It captures a vast representative cross-section of the country. By utilizing this registry, the researchers analyzed over 1 million individuals.
Over 1 million?
Over 1 million individuals who received a cancer diagnosis during the first 2 years of the pandemic, specifically 2020 and 2021.
Which gives us a robust sample to finally measure the pandemic's collateral damage. And the primary finding is, well, it's sobering.
Yes, it is. The researchers concluded that there were an estimated 17,390 more cancer-related deaths within just 1 year of diagnosis compared to pre-pandemic expectations.
That's within just the first year.
Just the first year. That represents a 13.1% increase in expected mortality for these patients during their most critical window of treatment.
What's fascinating here is how the researchers isolated that specific number.
Right, because of the obvious confounding variable.
Exactly, the virus itself. It would be so easy to look at a spike in deaths among cancer patients in 2020 and just assume
they caught COVID.
Right. Assume those individuals contracted COVID-19 while immunocompromised from chemotherapy and succumbed to the respiratory infection.
Which I actually have to push back on for a second. That 13.1% increase. When we're looking at a data set of over 1 million people, isn't there always going to be some natural statistical variance year over year?
Sure.
How do we know this isn't just a statistical blip or, like you said, just cancer patients dying from COVID?
That is the exact skepticism the researchers applied to their own data. To eliminate the statistical noise, they established a really rigorous baseline using patient outcomes from 2015 to 2019.
So a solid 5-year baseline.
Yes, they mapped out the trajectory of what a normal, functioning healthcare system produces in terms of survival rates. Then, to address your second point about the cause of death.
The COVID factor.
Right. They didn't rely on relative survival. They utilized a metric called cause-specific survival, or CSS.
CSS.
In this specific analysis, non-cancer causes of death, including COVID-19 infections, were censored out of the data.
Okay, let's translate that statistical term for a second. Because when people hear that data was censored out, the immediate assumption is often that something was hidden.
Or manipulated to fit a narrative.
Exactly.
That's a fair point of confusion. In statistics, censoring just means they mathematically separated the people who died from COVID-19 or car accidents or heart attacks.
Just removing the unrelated variables.
Exactly. So they could look exclusively at the cancer's direct impact. Think of it like filtering out background noise on an audio track so you can hear a single voice clearly.
That makes perfect sense.
They wanted to know if the cancer itself became more lethal during the pandemic.
Which means those 17,390 extra deaths were individuals whose cancer progressed and took their lives when, based on the 5 years prior, they statistically should have survived that first year.
Exactly.
Because the treatments themselves, the chemical composition of the chemotherapy, the radiation physics, those didn't suddenly fail in 2020.
No, the science didn't change.
The delivery system failed.
That is the core finding. Think of the healthcare system like a busy airport. In 2020, the pandemic effectively grounded all the planes.
Right.
But cancer is a ticking clock. It's like having a delay on flight when you urgently need to be somewhere. The delay itself becomes the emergency.
Wow.
The environment around the patient changed so drastically that their disease was allowed to advance completely unchecked.
So we have 17,000 deaths strictly from the cancer progressing. But when you apply that pressure to a country of over 300 million people, the system doesn't crack evenly everywhere, does it?
It never does.
Where did the fractures actually happen? Because the study shows that survival rates dropped for both early stage and late stage diagnoses across the board.
Yes, practically everywhere.
But certain subgroups experienced really severe concentrated impacts.
Yeah, and in population-level oncology, a full percentage point drop in a single year for any demographic is considered a massive anomaly.
A huge red flag.
The researchers identified two specific groups that experienced survival reductions greater than 1.00 percentage point for late-stage diagnoses.
Okay.
The first was individuals aged 65 and older.
Which, if you think about it, requires looking at the logistics of how that age group interacts with the medical system.
Definitely.
It wasn't just fear keeping them away, though that was a factor, obviously.
A big factor early on.
But this demographic also faced strict isolation policies in care facilities. And furthermore, when hospitals pivoted to telemedicine to triage patients, there was a significant technological divide.
Oh, absolutely.
Because an oncology consult often requires a physical examination. You need blood draws, you need imaging. That simply cannot happen over a video call.
The friction to access care became incredibly high for older patients.
Yeah.
The second group the data highlights is categorized as other non-Hispanic race. The study specifies this includes American Indian, Alaska Native, Asian, and Pacific Islander individuals.
And what was the drop there?
For late-stage diagnoses in this demographic, survival dropped by over 2 percentage points in both 2020 and 2021.
2 percentage points. That is a staggering disparity.
It really is.
It forces us to look at the systemic inequalities that existed long before the pandemic even started.
It does. A crisis doesn't invent new vulnerabilities. It acts as a magnifying glass on existing ones.
Right.
Many communities within that other non-Hispanic category rely on localized, underfunded clinics, like the Indian Health Service facilities.
Or community health centers in dense urban areas.
Exactly. When supply chains broke down for basic PPE, those smaller clinics were often the first to shut their doors entirely. Or they had to severely restrict access.
Because they couldn't absorb the shock.
Unlike massive, well-funded hospital networks, yeah.
The referral networks just completely broke down. If your local clinic is closed, you can't get the referral to the oncologist 2 towns over.
And language barriers, which are already a hurdle in complex oncology care, compounded the issue.
I didn't even think about that.
During the height of the pandemic, patient advocates and family members were barred from entering hospitals to limit infection risk.
Oh, right. You had to go in alone.
Navigating a cancer diagnosis without your support system or your translator present is an incredibly isolating and difficult process. And that naturally leads to delays in making crucial treatment decisions.
Here's where it gets really interesting. Because the researchers broke this down not just by demographic, but by the specific biology of the diseases.
Yes, the cancer types.
They separated the data into low survival cancers and high incidence, high survival cancers.
Let's examine the low survival cancers first. These are diseases that are notoriously aggressive. Their 5-year survival rates historically sit at roughly 1/3 or lower.
So we're talking about
Pancreatic, liver, esophageal, lung, and brain cancers. The margins for error here are already razor thin.
And the data reflects that vulnerability perfectly.
Yeah.
For early-stage esophageal cancer, the 1-year survival rate plummeted by 3.89 percentage points in 2020.
Just a devastating drop.
That is an enormous drop for a cancer that was theoretically caught early.
To understand why, we have to look at the treatment pathway for esophageal cancer. It typically requires a complex multimodality approach.
Right.
Weeks of chemotherapy and radiation, followed by a massive, highly invasive surgery called an esophagectomy. Is one of the most demanding surgeries a patient can undergo.
And it requires an intensive care unit bed for recovery.
Exactly. If the ICU is at 110% capacity with COVID-19 patients on ventilators, the surgical wing simply cannot perform an esophagectomy.
Because there's nowhere to put them.
There is nowhere for the patient to safely recover. So the surgery is postponed.
But the tumor doesn't pause.
No. A delay of just a few weeks gives an aggressive cancer the window it needs to metastasize, shifting the patient's prognosis from curative to palliative.
If we connect this to the bigger picture, you might assume that the common, highly treatable cancers would be more resilient to these logistical bottlenecks.
You would think so.
But the study looked at high-incidence, high-survival cancers like prostate and colorectal cancer and found shocking mortality increases.
Huge increases.
The data shows 25.4% more prostate cancer deaths within 1 year of diagnosis than expected, and 16.3% more colorectal cancer deaths.
Because these cancers are so prevalent, even a fractional drop in survival rates translates to a massive number of human lives lost. But those percentages, 25 and 16%, those are not fractional drops. They represent a fundamental breakdown in early intervention.
Wait, I have to stop you there and ask about the prostate cancer statistic.
Nope.
Prostate cancer is famously slow-growing. Oncologists often tell patients they are more likely to die with prostate cancer than from it.
That's a very common saying, yes.
So how does a single year of healthcare disruption cause a 25.4% spike in deaths for a slow-moving disease?
It is a brilliant question, and it points to a shift in when these patients were finally diagnosed.
The timing.
You're right that early-stage localized prostate cancer is slow-moving. But because routine PSA blood tests and urology exams basically plummeted in 2020, the men who were diagnosed during that time were not the ones catching it early.
Right, because nobody was getting routine checkup.
Exactly. The diagnostic pool became heavily skewed toward men who were already experiencing severe, unignorable symptoms.
So the 25.4% increase isn't because early-stage prostate cancer suddenly became aggressive.
No.
It's because the only people getting diagnosed in 2020 were the ones whose cancer had already advanced to a late, highly lethal stage.
Precisely the mechanism at play. The mild cases went completely undetected, while the severe cases, the ones that would have been caught a year earlier under normal circumstances, presented at hospitals when it was simply too late to alter the one-year survival trajectory.
Which brings us to a fascinating contrast in the study, the breast cancer anomaly.
Yes, this is really interesting.
The data shows that female breast cancer experienced very limited one-year survival impacts compared to colon or prostate cancer. The disruptions happened, but the survival rates barely registered a drop. Why did breast cancer care weather the storm so much better?
It comes down to the mechanics of the screening process and the agility of outpatient clinics. Early in the pandemic, around March to May of 2020, mammograms plummeted just like every other screening.
Everything stopped.
But by June of 2020, breast cancer screening rates had almost entirely returned to expected pre-pandemic levels.
But why did mammograms bounce back in 3 months, while colonoscopies and lung screenings remain heavily disrupted for over a year?
Look at the resources required. A mammogram is a relatively quick, non-invasive imaging appointment. It happens in an outpatient clinic. A colonoscopy or a lung endoscopy is an invasive, aerosol-generating procedure.
Which was the buzzword of 2020, aerosol generating.
Oh, absolutely.
Mm-hmm.
Anything that required airway management or taking off a mask was considered high risk for transmitting the virus to healthcare workers.
So they just didn't do them.
Beyond the transmission risk, consider the supply chain. A colonoscopy requires an anesthesiologist. It requires sedatives like propofol or fentanyl. It needs dedicated procedure rooms and recovery nurses.
And all of those were reassigned.
In 2020, anesthesiologists were redeployed to manage ventilators in the ICU. Sedatives were in massive global shortage because they were being used to keep intubated COVID patients comfortable.
That makes so much sense.
The resources needed to screen for colon cancer were literally consumed by the virus. Mammography, thankfully, did not require those overlapping resources, which allowed outpatient imaging centers to implement safety protocols and reopen rapidly.
So what does this all mean? We've explored a mountain of data today, from the overarching 13.1% increase in expected mortality down to the supply chain shortages affecting colonoscopies.
Yeah, there are a lot of moving parts.
How do the researchers synthesize all these logistical failures into a cohesive explanation for those 17,390 extra deaths?
The study categorizes the failure into 3 primary drivers. First, time to treatment delays.
Like we saw with the esophageal cancer.
Exactly. Postponed surgeries and overwhelmed ICUs allowed tumors to advance. Second, interrupted care. Patients who were already diagnosed and undergoing chemotherapy had their regimens stretched out.
Because they couldn't get in for their next dose.
Or because chemotherapy requires constant monitoring of a patient's white blood cell count. If the diagnostic labs are backed up, processing millions of PCR tests, the oncologist can't safely administer the next dose of chemo.
And the third driver is the one we've seen in the prostate and colon cancer data, the underdetection of asymptomatic cases. the silent progression of disease just because the routine maintenance of our health was paused.
This raises an important question. How does this data fundamentally change how you, the listener, interact with the medical system today?
Right.
Because it is very easy to look at a study from 2020 and 2021 and dismiss it as a historical artifact of a chaotic time.
A once-in-a-century event. But the lesson here is intensely personal and it's entirely applicable right now.
Absolutely.
We all live incredibly busy lives.
Yeah.
It is so common to look at your calendar and say, I'm too swamped this month, I'll push my skin check back half a year, or I'll reschedule that routine blood work after the holidays.
This research quantifies the danger of that mindset. Time is not a neutral factor in biology.
No, it's not.
A postponed screening is not just a scheduling inconvenience. It is a measurable risk. The data proves that relying on a strained system to automatically catch you if you fall through the cracks is a dangerous gamble.
It requires a shift from being a passive recipient of healthcare to an active advocate. If a clinic cancels an appointment due to staffing shortages, the burden often falls on you, the patient, to relentlessly pursue a rescheduled date.
And that administrative friction is frustrating. But this JAMA study puts a very real number on the cost of letting that friction deter you from getting care.
The virus was the immediate threat, but the secondary toll, the disruption of the complex choreography of modern medicine, proved to be a deadly force all on its own.
The ecosystem requires constant maintenance, both at a macro, systemic level, and at an individual level.
Let's bring all these threads together. The mission of this deep dive was to look past the viral infection rates and uncover the hidden tragedies embedded in the pandemic's early years. The SEER 21 data revealed 17,390 extra cancer-related deaths within a single year of diagnosis. We've seen how rural clinic closures, ICU capacity limits, and even the global supply chain for sedatives conspired to delay diagnoses and interrupt life-saving treatments.
And the authors of the study conclude with a vital call to action for the healthcare industry. Rebuilding capacity just isn't enough.
No.
Systems need intentionally designed redundancy. Health networks must also become far more proactive in their patient communication. They need to actively identify individuals who missed their routine screenings during the pandemic and guide them back into the care pathway before asymptomatic diseases become late-stage crises.
We've covered a tremendous amount of ground today, analyzing how the environment around a patient can be just as critical as the disease itself.
We really have.
But before we wrap up, we want to leave you with a final, lingering thought to explore on your own. We now have the hard data showing the collateral damage of a system pushed past its breaking point. Looking to the future, if a single year of postponed appointments and strained hospitals caused this much measurable secondary damage to cancer survival, how might we completely redesign the architecture of our global health systems so that routine life-saving care becomes entirely disruption-proof during the next global crisis?
It requires rethinking the very foundation of how we deliver care. But as the numbers show, the cost of the status quo is simply too high.
Thank you so much for joining us on this deep dive. Keep asking questions, keep advocating for your own health, and we will catch you next time.